Cleanup batter, eh? I'm not very good at baseball or softball or anything that involves a ball, actually. My name is Marcy Nielsen. I'm the president and CEO of the Patient-Centered Primary Care Collaborative. How many of you have heard of the PCPCC? Wow. Well, we have a really bad acronym, but it's memorable. We're going to do a little speed dating here because today we've been fairly in the weeds on a number of issues, certainly as it pertains to certification, accreditation, etc. And I'm going to pull us back out of the weeds, but we're speed dating, one, because I have a lot of slides, but this whole thing scares me. And I see you didn't turn it on yet, which means, am I supposed to turn it on?
It's on now.
Oh. Damn. So this thing scares me. Because I have a lot of slides, but I talk quick. Secondly, you've been talking about accreditation, certification as it pertains to training. So you've been in that warm, fuzzy space, dating for a long time. Other, perhaps, behavioral health specialists. How many of you are clinicians? Wow. How many of you are academics? Okay, big overlap there. How many of you are parents? Okay, how many of you are here only representing your role as a parent? And how many of you are other? Okay, so we got a couple of others. Well, I'm going to ask you to meet me in the world of primary care and health policy nerddom as we speed date. And instead of sort of doing the thing that you're kind of used to, which is, I think, again, talking about training, and maybe that's like going to the last Harry Potter movie. How many of you saw that? Yeah, me too. Great? No, good, but not great. I'm going to ask you to do something a little different, like bowling. I'm going to ask you to step out of the world of training for a minute and think about the delivery of services and what accreditation/recognition looks like if you approach it from that perspective. So think primary care, think health policy, think accreditation of services, a delivery model, if you will. And that requires me to give you a little bit of background on the patient-centered medical home. How many of you feel like, yeah, I got this, Marcy. I know what a PCMH is. Okay, well, that's good. Because I'm gonna go through this quickly. But important to understand that although the patient-centered medical home is a term that you may hear a lot, it is not one that is monolithic. In fact, the patient-centered medical home is a little bit like you've seen one PCMH, you've seen one PCMH. They differ by marketplace, by the consumers that they serve, and I'm going to tell you more about that. But essentially, there are 5 key attributes that are important and should look very familiar to all of you, given the topic that you've been focused on here today. I'm going to tell you more about these 5 attributes because not unlike the discussion that you've had all day, the world is changing. Definitions need to change, modernize, and models of care are certainly changing. You've also talked a lot today about wellness and prevention, and I should tell you I'm trained in public health. I told you I was a health policy nerd, and I trained at Hopkins, but actually you could get your PhD in social and behavioral science, that's what my PhD is in the Department of Health Policy and Management. So I would encourage all of you as you think about the PCMH here and you think about whether or not there's some utility in the goals that you are setting around this conference, whether or not everybody needs a little more health policy nerd in them, because we all need to kind of hold on to our hats. If we thought that the last 8 years was busy with the passage and the implementation of the Affordable Care Act, wow, I think things are about to get busier. The concept of patient-centered medical home really was one that was born out of primary care and pediatrics in particular. But I would want you to know that the folks who are thinking a lot about this model, and my organization really is sort of the membership organization that advocates on behalf of this model, or advanced primary care, or high-performing primary care, whatever you want to call that acronym. The goal, the theory would be the delivery of healthcare services for patients and families that are of high value. And you cannot do that in a primary care practice all by itself behind the four walls of a clinic. You must partner with the rest of the medical neighborhood, and you see only one box, although I chopped off its head, behavioral and mental health clinicians. We are strongly preferential to integrating behavioral health services into primary care when appropriate. But increasingly, and you've talked a lot about this today as well, the social determinants of health, the places where health is made really isn't in a clinical setting at all, but it is where we work and play and worship, and certainly when we're talking about children, it's also in schools. Now, the PCMH does come out of the world of pediatrics, and I see that Fan Tate was here earlier, and she's already left, but last year we actually celebrated Dr. Calcia, who was the pediatrician in Hawaii who actually founded the concept in 1967. And you didn't hear about the medical home concept outside of pediatrics too much until some of the other primary care physician organizations started to embrace it and test it. And then you'll see in 2006, the PCPCC was founded. Now, it was founded by the 4 primary care physician organizations. So family practice, pediatrics, the Osteopathic Association, and the American College of Physicians. But physicians are not monolithic as a profession either. And today we have extended well beyond those initial physician organizations, and they partnered with IBM, by the way. So the initial partnership started with this coalition between healthcare providers and payers. And that's really important because as an outsider, and I should say, first of all, thank you for inviting me and including me in the first place. But what I'm not hearing a lot today is where your Venn diagram across health professions is. So we've got one. We created it 10 years ago in primary care, and Doug Tynan is here. The American Psychological Association has long been a member. We are increasingly including the psychiatrists, the clinical psychiatrists, social workers, etc. But you can see the public and the role of patients and families in particular is incredibly important in everything that we do. And we've come together, sort of the middle of that Venn diagram, and advocated on behalf of this model. And as I mentioned, hold on to your hats, the world is changing. It's changed a lot in just since 2007, in the last 10 years. We started testing this model of care, again, very different depending on where you implement it. We saw the real leadership coming from states and local regions where we had grant dollars or state dollars to implement this model of care and to test whether or not it was efficacious. Was it effective? Did it save money? Did it improve health outcomes? We started to accredit and certify this model, and really NCQA started that process in 2008, and I'm going to talk about that in particular. But you have said, almost every single person has at least referenced the notion of sustainability and affordability, and how do we pay for this care in a way in which we can know at the clinic level that this isn't going to whatever it isn't going to end when the grant dollars run out. And this is where the passage of the Medicare Access and CHIP Reauthorization Act becomes increasingly important to us, and I think it's going to be increasingly important to your work, and I'll say a little bit more about that. So what does that mean? What is next? Medicaid, which, as you know, was expanded in the Affordable Care Act, but stopped by the Supreme Court as a mandated expansion across all 50 states. Medicaid is where most of the best patient-centered medical home work for children happens. So Medicaid is critically important, and it is in particular important for behavioral health. And so all of the places where you see Medicaid and medical home activity, we've got several. All of the yellow dots there are multi-payer efforts, and I'm going to come back to that, because this notion of collaboration and unifying speed dating with folks outside your comfort zone becomes important. This can't just be about saving money, although that's important. It can't just be about improved quality or better patient experience if clinicians are so burned out that they can't do this work anymore. And that is where we find ourselves today in primary care. I've got 9 seconds to tell you everything about PCMH accreditation. We all know we're not doing a whole lot to bend the cost curve. We made some dents, but we need to increasingly focus on healthcare expenditures, because this next Congress and our new president are going to have a lot to say about public spending for healthcare. And where certification and recognition come in is several of the panelists today talked about some of the granular aspects of their accreditation programs, and I serve on the American Board of Family Medicine as their public member. So I know an awful lot about ACGME, and I'm on the certification committee, so I know an awful lot about certification. But what I'd invite you to do over the course of the next day is to think about what you want to achieve, because where we've gotten into a bit of hot water on PCMH is everybody disagrees what it means to be certified. Is it a good housekeeping seal of approval? And if you've got that sticker on your window, you offer a certain kind of care already? Or is it a process for payers and purchasers to say, check, you get an increased reimbursement, I don't have time to look over your shoulder and see if you're offering evidence-based care? Or is it a quality improvement process? Because that's really how the concept of PCMH was founded in 2006 when the joint principles of PCMH were advanced. I will end by telling you, if you go down the accreditation or recognition route, be very, very careful, because as you know, lots of granular details need to be worked out and agreed upon. And then you become the tester. You are the person who isn't necessarily the enemy, but you aren't the friend anymore. You aren't the advocate. You lose this North Star aspirational guide, because now you are the professor who is handing out the test, and the competencies that you're testing suddenly make clinicians grouchy. It made our board grouchy. So we asked a group of experts, this diverse group of individuals, to come back and tell us what's wrong with accreditation. What are we doing wrong in patient-centered medical home accreditation that we feel like we're missing the North Star? We're so focused on checking the boxes and meeting each of these granular details, we've sort of lost the forest through the trees. What's the goal of ACGME? What's the goal of any of these individual programs except good patient and family-centered care, right? We can't lose the North Star. So I won't read these to you except to say we had lots of advice. And the good news is, as much work as is required to find unity across all of these disparate perspectives, very complicated laws like MACRA. This is MACRA in one slide. This is when I invite you to be a health policy nerd. Very complex piece of legislation, but our recommendations as part of the PCMH accreditation work group that I just shared with you changed what CMS ultimately did and who will get to be a patient-centered medical home, which means dollars in the pockets of those clinicians who, by the way, very rarely pocket the money and go home. They use it to invest in their clinic and to expand access to care. So for whatever lessons we have learned, I am happy to share with you. I thank you very much for inviting us, and I thank you for your participation as we continue to update what it means to offer the principles of now person-centered, team-based primary care, and happy to take any questions.